Hello, Clinic Review family. Let's talk today about pulmonary embolism. It is from the Blue Book, so let's go ahead and get started. Hello, my friends. It's Dr. Sharon with Clinic Reviews. You know, we are part of the greater Clinic Review organization. Mark Klimek started Clinic Reviews over 40 years ago, and he is the absolute GOAT of Nclex reviews. We are a primarily Nclex review channel. He does online on demand 21 plus hours of Nclex prep. If you want to sign up for that, go to clinicreviews.com. We also have small group tutoring where we cover next gen and prioritization, as well as some other things. And we have a streaming service. So go to clinicreviews.com to find out more about those things. All right. So Mark Klimek wrote the Blue Book a long time ago. He's updated it recently and he's now selling it on Amazon. The Blue Book is a book of facts that you need to know. And one of the facts, information that's in there is about pulmonary embolism. So what I do is I recommend that you purchase the book. I don't make any money off of that. So it's not, I'm not enriching myself by recommending you buy the book. And then I write Nclex questions to go along with the content in the Blue Book. So if you've gotten the Blue Book, that would be great. You can study the information in there and then test yourself with the questions that I write. And sometimes the questions aren't obviously coming from the Blue Book, and you have to kind of use good clinical reasoning and clinical judgment to answer them. So let's go ahead and get started. You know that this is primarily an Nclex prep channel. It's also good for preparing for any standardized tests that you might have as part of your nursing program. So let's go ahead and get started. Which event most commonly precipitates a pulmonary embolus? Air entering the circulation after central line removal, fat globules released after a long bone fracture, amniotic fluid embolizing during labor, or thrombus migrating from deep veins of the legs or pelvis. So 90% of pulmonary emboli come from a blood clot in the leg. So DVT is one of the biggest risk factors, thrombus, blood clot, biggest risk factors for pulmonary embolism. It can be air, it can be fat. Those are uncommon. And what you really need to know is if your patient comes in with a DVT, you need to be careful about them developing a PE. 4 post-op clients are in the PACU. Which client is at highest risk for developing a pulmonary embolus? 19-year-old after emergency appendectomy, 38-year-old 36 weeks pregnant after open reduction of a fractured tibia. Wow, she's pregnant and had surgery. 55-year-old after laparoscopic cholecystectomy, 72-year-old after cataract extraction. So usually what I do when I get a risk factor question is I count the number of risk factors, and age, unless you know age is a risk factor, I don't usually count age as a risk factor. So I'm just going to go with they all have had surgery. So surgery is a risk factor. Pregnancy is a risk factor. Use of oral contraceptives is a risk factor. And fractures of bones is a risk factor. And the femur is one of the biggest bones. Oh, I'm sorry, it's tibia, not femur. Femur is very high risk. Tibia, leg fractures also are high risk. So we have A is just one risk factor. C is just one risk factor. D has just one risk factor. B clearly has 2 risk factors. She's pregnant and actually 3. She's pregnant, she had surgery, and she had a bone fracture. So she's definitely the highest risk. A nurse is caring for a patient who suddenly becomes restless. Which findings should make the nurse suspect an evolving pulmonary embolism? Select all that apply. Sudden pleuritic chest pain, productive cough with thick green sputum, unexplained tachycardia, diminished breath sounds at the left base only, sense of impending doom, or new onset dyspnea. Okay, so classic signs and symptoms are something you should definitely know. When you say, for example, do next gen case studies and you have a set of the patient comes in with certain complaints and then they ask you to hypothesize what the problem is, you have to know the classic signs and symptoms so that you're not like doing a random guess about what the problem could be. One of the key things related to pulmonary embolism is these are sudden onset symptoms. So if they've had the symptom for a week, it's probably not a pulmonary embolism. This is sudden onset. So sudden onset chest pain definitely is a indicator of possible pulmonary embolism. Productive cough, hemoptysis, not green sputum. So we want to see hemoptysis, not green sputum. So B is out. Unexplained tachycardia, Certainly, they're not oxygenating, and when they're hypoxic, they're gonna a heart rate's gonna go up to try to compensate for that. Diminished breath sounds. Embolus is not a ventilation problem; it's a perfusion problem. So it's not really about diminished breath sounds. It's about picking up the oxygen that comes into the lungs. So D is out. Sense of impending doom. When they have a pulmonary embolism, they feel like something's going on here. This is not right. New onset dyspnea, new onset, it could say sudden dyspnea. The key ones, A and F, absolutely have to be there. I would not say that they're having a pulmonary embolism on the Nclex unless I see A and F. Those are very classic signs. C and E are common. They don't have to be there, but they're very common to go along with pulmonary embolism. A post-op client suddenly complains of shortness of breath and sharp chest pain. See, they even give you the classic signs and symptoms when they want you to know it's a pulmonary embolism. The nurse notes an SpO2 of 84% on room air. Which action is priority? So I'm thinking pulmonary embolism, but they're also extremely hypoxic. Obtain a stat portable x-ray, notify the rapid response team, administer 2 liters oxygen, place the client in high Fowler's. So this is a prioritization question where they say, what is the most important thing to address? So there's a couple ways to prioritize. You can do acute versus chronic. Well, all of these are acute problems. The shortness of breath is acute, the chest pain is acute, and the SpO2 is acute. So I can't use acute versus chronic. And I can't use ABCs unless they are all physiological or objective. In other words, measurable. Shortness of breath is subjective, sharp chest pain is subjective, and SpO2 is objective. So I can't use ABCs because they're not all objective. So what I can do is say, I'm going to treat the objective problem first. And the objective problem is the 84%. So I have to put oxygen on them. Now, listen, if somebody told you, oh, do a stat portable chest x-ray. First of all, chest x-ray is not classic diagnostic test for pulmonary embolism. CT scan is, you can do a VQ scan. And you might say, well, no, we have to notify the rapid response team. On the Nclex, there has to be an objectively right answer. If it's just someone's opinion about what should be done first, then it's not an objectively right answer. I'm teaching you how to pass a test. And in order to get the objectively right answer, there has to be some rule that we're following. And when we come to prioritization questions, there has to be a rule. And the various rules are acute versus chronic, objective over subjective. And then if you have multiple objective problems, you can use ABCs. In this case, we only have one objective. So we're going to go ahead and administer 2 liters of oxygen first. Sometimes I get messages from people saying, well, I think it's B. That's fine if you think it's B. But what you're doing is you're answering it based on your opinion, and opinion answers are not great answers. Like, you might get it right if your opinion matches the rule, but opinion answers on the Nclex are not great answers. Remember, I'm teaching you how to answer test questions. I'm not teaching you how to be a nurse. If your hospital wants you to call a rapid response first, you do what your hospital tells you. I'm telling you how to answer test questions. A patient admitted with pulmonary embolus asked why they are still on IV heparin when they are starting their Coumadin. The nurse's best response is, heparin can be reversed quickly, while warfarin is difficult to reverse. Heparin reverses warfarin-induced bleeding. Warfarin takes several days to become therapeutic. Heparin is more effective than warfarin, but cannot be taken at home. All right, why do people, it's called bridging, where they bridge from heparin over to warfarin. Why do people bridge? People bridge because it takes a while for warfarin to become therapeutic. So they stay on the heparin until the warfarin becomes therapeutic. So the correct answer is C. Now, A is a true statement, but that's not why we bridge people, okay? B is false statement, and D is a false statement. Heparin can be taken at home if you teach them how to do sub-Q injections, but it's not more effective than warfarin. A PE patient bridging from heparin to warfarin has an INR of 1.7 on day 3 of therapy. What is the best nursing action? Administer the scheduled warfarin dose and continue heparin. Hold today's warfarin dose and stop heparin. Give vitamin K 5 milligrams PO. Notify the provider of critical INR. So this is a lab value that you should actually know. A therapeutic INR is 2 to 3. It may even go up to 3.5. But INR of 1.7 is subtherapeutic. So we want to continue the heparin until the warfarin becomes therapeutic. So we're going to administer the scheduled warfarin dose and continue heparin. Which dietary statements indicate correct understanding of warfarin therapy? Select all that apply. I will avoid cranberries and grapefruit juice. I can eat broccoli as long as I keep the amount consistent. Aspirin is safe because it thins my blood like warfarin. I should use an electric razor instead of blades. Alcohol binges can make my bleeding risk worse. Well, these are not all dietary statements, but all right. So warfarin, we have to avoid vitamin K. Well, not avoid vitamin K. You have to eat a consistent diet of vitamin K. Okay, so that's clear. And we always tell people don't drink alcohol when you're taking a prescription medication because it can mess up the amount of that medication in your blood because it messes with binding and all kinds of stuff. So broccoli has vitamin K in it. So I can eat broccoli as long as I keep the amount consistent. That's a true statement. And we want correct understanding. So B is true. And E, alcohol binges can make my bleeding risk worse. That's true. So I know B and E are true statements. Now, should they avoid cranberries and grapefruit juice? Cranberries and grapefruit juice don't have vitamin K in them, but they are known to interfere with binding of medications, particularly grapefruit juice. The thoughts are changing on cranberries at the moment. So I'm not sure if they'll test on cranberries, but they definitely can test on grapefruit juice. It's absolutely contraindicated when taking any prescription meds. So A is true, B is true, and E is true. Now, aspirin is not dietary, but I'm still going to look at it. Aspirin's safe. That's not true. They usually avoid aspirin unless it's prescribed when taking warfarin. So I'm going to say C is false. I should use an electric razor instead of blades. That's true. They should use an electric razor. It's safer than straight razor blades for shaving. So those are the correct statements. I don't know why it says dietary. They're not all dietary, but they are all correct statements. A client with suspected PE is restless and tachypnic. Which assessment data require immediate follow-up? Capillary refill 2 seconds, blood pressure 88/54, heart rate 106, temp 100. Now, normally when you get a question like this, they tell you that they have a diagnosis and they say, which are you most concerned about, or which require immediate follow-up, or which should you call the doctor about? I look for the unexpected finding. Capillary refill is fine. That's not unexpected. Blood pressure is low. It's quite low, very low, I'll say, very low. That's unexpected. Heart rate of 106. With a PE, I would say that's expected because the heart rate is up. It's trying to compensate for the poor oxygenation. So I would actually say being a little tachycardic is expected with a PE. Temperature of 100 degrees Fahrenheit. That's high normal. I mean, I really don't worry about a temperature, a fever until it gets probably over 100.5, sometimes even 101. Like, I'm just not worried about a low grade temp like that. Like, that's just, some people would even say that's normal. At best, it's a low grade temp. So am I more concerned about a very low blood pressure or a low grade temp? Because A and C are expected. So B and D, I wouldn't even, honestly, I can't really say D is unexpected. I mean, the body is under assault. It's hypoxic. It's under stress. The fact that the temperature would go up a little bit as the body's trying to adjust for this, that's kind of expected. So low blood pressure is definitely unexpected. And the PE, the worse the PE, the more they're going to look like they're going into shock. So the fact that their blood pressure is falling like that is a big concern. I don't expect my PE patients to go into shock. That's unexpected. If they do start to go into shock, that means they've got a massive PE and we've got to take immediate action. A patient with a confirmed massive PE is being evaluated for alteplase, which is a clot busting drug. Which history elements are absolute contraindications? Select all that apply. So absolute contraindications means there's no exceptions to this rule. Absolutely always, if they have this in their history, they cannot get clot busting meds. Ischemic stroke 7 months ago, active peptic ulcer bleed last week, blood pressure 182/108, recent lumbar puncture 2 days ago, traumatic brain injury 3 weeks ago, platelet count 180. Okay, so absolute contraindications. An ischemic stroke is not an absolute contraindication. In fact, we treat ischemic strokes with clot busting drugs as long as they don't have any contraindications for that. Now, a hemorrhagic stroke could be a contraindication, but 7 months ago is long enough. I usually go with about a 3-month window. I usually think about 3 months is sort of, because these things are changing. It seems like these things change all the time, but 3 months is sort of a safe time frame for these kind of things. So ischemic stroke 7 months ago does not concern me. Active peptic ulcer bleed last week, that was just last week. That's within that 3-month window. I'm concerned about that. Blood pressure. So if it was uncontrolled hypertension and we couldn't get it down, I would start to say it might be contraindication, an absolute contraindication, but I don't know that I can't get this blood pressure down. And if we can get the blood pressure down and then we can give the alteplase, it's really important to give the alteplase if we can. So we're going to try to get that blood pressure down. So it's not an absolute contraindication. Recent lumbar puncture 2 days ago. Okay, that worries me. 2 days ago. Now, that's different than a bleed. If they've had a bleed, I usually say 3 months. If they've had a procedure like a lumbar puncture, because there's no evidence it bled out. It's just a recent procedure. I would say a week. So usually a week is about the time frame I look at for recent procedures. But this was just 2 days ago. Traumatic brain injury 3 weeks ago. Traumatic brain injury makes me think, I mean, that's a trauma. They could have been bled out. Like, that's concerning to me. So I would think that would be contraindication just 3 weeks ago. Platelet count is fine. So I'm not worried about that. So I put this on here so you could kind of see. So you can see that I put 3 months next to the ischemic stroke and the traumatic brain injury, because I usually look at, if they've had bleeding in their past, then I'm concerned at the 3-month mark. And that would also be true next to peptic ulcer bleed, 3 months. And then blood pressure, I'd be concerned if it's uncontrolled. And a procedure, I would be concerned, an invasive procedure, not a non-invasive procedure. An invasive procedure, I'd give it about 7 days before I'd want to do the alteplase. So those are some pretty standard general rules that I think if you follow those, you'll be pretty safe on the Nclex. Which symptom most strongly suggests a massive pulmonary embolus? Sudden productive cough with hemoptysis, sharp unilateral chest pain worsened by inspiration, acute syncope with pulseless electrical activity, oxygen saturation dropping from 97 to 90. Okay, all of these are symptoms of PE. A, B, and D are classic symptoms of PE. They're sudden cough, sharp pain, oxygenation dropping. What's not common is pulseless electrical activity. The reason I want you to know this is because it's not even really for the Nclex. It's more like for real life. When people develop pulseless electrical activity, which means they have a rhythm they have an electrical rhythm, but they have no pulse. So in other words, their heart is not responding to the electrical conduction in the heart. You have to do CPR, but you're never going to get them back to a rhythm, a normal conduction, unless you figure out why. There's various reasons why. For example, metabolic acidosis can cause pulseless electrical activity. Massive pulmonary embolism can cause pulseless electrical activity. So if you're working in the ED and somebody comes in PEA, you and the provider are going to be working to try to figure out why that is. And they're going to have to correct that before their heart's going to get back into normal function. The nurse is caring for 4 PE patients on a telemetry unit. Who should be assessed first? On warfarin, INR 3.1, mild bleeding that stopped. On heparin, platelet drop from 240 to 89. Complains of dull calf ache, Doppler scheduled later today, reports anxiety and requests sleep medication. So it says who would be assessed first. Really what it's saying is who has the most unexpected findings, or who is most unstable. Someone who's on warfarin has an INR of 3.1. That's therapeutic. I mean, you can go up to 3.5 and be therapeutic. So, and it's just a mild bleeding, which isn't that surprising when you're on warfarin at a therapeutic range. Heparin sudden drop, that's called heparin-induced thrombocytopenia. We usually have to stop all heparin products when that happens. So that's a concern. Complains of dull calf ache, Doppler scheduled later today. So the number one cause of a PE is a DVT. So does it surprise us that someone might have a DVT? Of course not. That's not going to surprise us. And they're scheduled for the test that they should have scheduled. So it's all good. Reports anxiety and requests sleep med. Those are very vague symptoms. It's not enough for me to be concerned about. So I have to be concerned about the heparin-induced thrombocytopenia. Thrombocytopenia, that vocabulary word means low platelets. Normal platelet count is 150 to 400. Okay, 150 to 400. So it went from normal 240 to 89, which is quite low. Which nursing interventions help prevent PE in high-risk hospitalized clients? Select all that apply. So who's at high risk in the hospital? If they had recent surgery, particularly in orthopedic surgery, if they're taking estrogen, birth control medications, if they've had a recent delivery, birth the baby, immobility, these are all things that put them at risk. Okay, early ambulation. These are interventions to help prevent PE. Early ambulation after surgery, placing pillows behind the knees for comfort, applying SCDs, encouraging adequate hydration, teaching ankle pumping exercising or main exercises, maintaining bed rest for 48 hours post-cesarean section. Well, I hope all of you know this. This is not a hard question. I don't think it's hard. But I just want to make sure you know it. You don't want to miss a question like this on Nclex. So you want to get them up and walking. And if they can't get up and walking, do some active range of motion that's going to get blood flowing, right? So early ambulation is good. SCDs is good. That gets the blood moving through the legs. Ankle pumping exercises is good. So A, C, and E are essentially all the same intervention, just different ways of doing it. So I like A, C, and E. We're not going to maintain bed rest. That's out. F, that's out. Staying hydrated is actually good. It's not the primary way that we prevent PE, but it's better than not maintaining hydration. So we're going to do D. And then should we put pillows behind the knees for comfort? Actually, no, because it compresses the vessels. And when the vessel's compressed, slows blood flow, and they can throw a clot in that area. So that's not good to do. So these are the things that you should know are appropriate for DVT prevention. They can do Lovenox, which is low molecular weight heparin, or heparin sub-Q. These are both also preventative measures. Though if one of those had been there, I would have picked it. If it said administer enoxaparin as prescribed, I would have picked it, no problem. Which laboratory value is most important to monitor for a patient receiving low molecular weight heparin, enoxaparin? International normalized ratio, activated clotting factor, hemoglobin hematocrit, activated partial thromboplastin time. So INR is for Coumadin. PTT is for heparin. I have to be honest, I don't know what the activated clotting time is right offhand. I would have to look it up. But we don't really monitor anything for Lovenox. We just want to make sure they're not bleeding. So the only one here that is appropriate to monitor when someone's taking a medication that can increase bleeding is to monitor hemoglobin hematocrit to make sure they're not bleeding. So this is a little bit of a trick question. It requires you to use common sense and clinical reasoning. Don't overthink it. Don't go, well, I don't know what the ACT is for. It must be ACT. Okay, if you don't know what it's for, y'all, don't pick it. Like, as a general rule, I don't pick answers if I don't know what they're for, unless all the others are clearly wrong. I know A is wrong. I know D is wrong, but C makes sense. It just makes common sense. Clinical reasoning tell me we'd monitor H&H when someone's on a medication that could cause bleeding. A patient receiving IV unfractionated heparin has an APTT of 32 seconds. The control is 28. What should the nurse anticipate? Decrease the infusion rate per protocol, increase the infusion rate per protocol, decrease the infusion rate per protocol, continue the current rate. It's therapeutic. Stop heparin and prepare protamine sulfate. Protamine sulfate is the antidote for heparin. All right, so the rule is that we want to keep, for therapeutic PTT, should be between 1.5 and 2.5 of the control. So between 1.5 and 2.5 of the control. So if I say the control is 28, and this is in the blue book, by the way. So 28 times 1.5 is 42. So that should be, I should at least have a PTT of 42. And then 28 times 2.5 is 70. So my therapeutic range for the PTT is 42 to 70, and it's only 32. So I need to increase the infusion rate per protocol. A PE survivor is discharged on warfarin. Which instructions should the nurse include? Select all that apply. So going home on warfarin. Wear a medical alert bracelet stating anticoagulant therapy. Take ibuprofen for minor pain rather than acetaminophen. Use a soft bristled toothbrush. Expect dark tarry stools. Schedule INR checks as prescribed. Stop warfarin 24 hours before all dental cleaning. Okay, so someone goes home on warfarin. What do they need to know? Well, we definitely need to get their INR checked. Okay, that's regular INR checks are important. So E is important. We need to maintain the same amount of vitamin K intake. That's actually not there. They should wear a medical alert bracelet because they're on warfarin, and we don't want them to bleed out and have nobody know why that's happening. So that's good. Ibuprofen increases bleeding. So we don't want them to take anything that can increase bleeding, including alcohol, ibuprofen, not aspirin. So they don't take any of those things without direct approval from the doctor. Soft bristle toothbrush reduces their risk of bleeding. Expect dark tarry stools. Absolutely not. Dark tarry stools means they're having some kind of a GI bleed. If they're having dark tarry stools, they need to call the doctor. They should not expect that. Now, it may not be a big deal in the end, but if they have dark tarry stools, they need to call the doctor. They're going to have to do some kind of a colonoscopy or EGD or something to see where the bleeding is coming from and is it a problem. Stop warfarin 24 hours before all dental cleanings. Now, they should stop warfarin before dental cleanings, but it's not just an umbrella order. We say you have to call the doctor to see when and if you can stop it. Because if they had a PE, you can't just stop the warfarin, or it could come back. Okay. So the instructions that should be included are A, C, and E. A PE patient's ABG, pH is 7.5, PaCO2 of 30, PaO2 of 58, and a bicarb of 21. How should the nurse interpret this? Metabolic alkalosis, respiratory alkalosis, metabolic acidosis, respiratory acidosis. All right. Well, first of all, it's 7.5. Normal is 7.35 to 7.45. So if the pH is high, it's alkalosis. So it's either A or B. Okay. And it says with hypoxemia, is that correct? 58 millimeters of mercury. It should be 80 to 100. So they're definitely hypoxic. Okay. So it's one of those. It's alkalosis, metabolic or respiratory. How do we tell the difference? Well, remember, respiratory opposite, metabolic equal. So they're alkalotic, and so the pH is high and the bicarb is low. That's respiratory opposite. So what we have is a respiratory alkalosis. Now, that is confirmed by the fact that the CO2 is low. Okay, so a low CO2, they're blowing off all this CO2, the pH goes up, the bicarb goes down to try to compensate for that. That's why we have these numbers. But you can use respiratory opposite, metabolic equal. If you need more instruction on that, I have an entire video on ABGs. So go and watch it. It's very good. Well, I think it's good. Okay, here's a protocol. Bolus 80 units per kilogram, then infuse 18 units per kg per hour. Patient weighs 154 pounds. How many units for the initial bolus? All right, so this is a bolus question. So 80 units per kg. So they weigh 154 pounds. So we have to convert that to kg. So 154 divided by 2.2. Okay, so how can you see this? 154 divided by 2.2 is 70. So they weigh 70 kg. So we multiply 80 times 70 and we get 5,600. Okay. So 80 times 70, 5,600. So that's the correct order for the bolus. I do have a video on calculating heparin drip. If you want to watch that, just type in heparin Climic or Climic heparin, and it should come up in the search engine on YouTube. Orders for PE patients include heparin, 20 units per kg per hour IV continuous, warfarin, 5 milligrams PO daily, phytonadione, 10 milligrams IV now, obtain INR daily. Which order should the nurse question? The heparin, the warfarin, the phytonadione, or the daily INR? Well, even if you don't know what phytonadione is, you know the heparin's fine, the warfarin's fine, and the INR daily is fine because you know all those things are fine. So why do I have this question in here? I want you to know that on the Nclex, phytonadione is the word they're going to use for vitamin K. So you need to know the vocabulary phytonadione. That is vitamin K. That's what they're going to use on the Nclex. And you should question vitamin K because it reverses warfarin. So why are we starting warfarin at the same time that we're giving vitamin K? That does not make any sense. So 2 reasons. I want you to know the vocabulary word, and I want you to know it's the antidote to warfarin. They should not be given at the same time. Okay, I hope that was helpful to you. Get the blue book, study that information. There's a few things in the blue book that I didn't cover, a few things I covered here that aren't in the blue book. Thank you for being a part of the Clinic Review family. Good luck on your NCLEX. Thanks.